50 of hydrochlorothiazide versus 25 of chlorothalidone, then you're talking about there's probably not much difference in blood pressure. I think you see more urgency on the 50 of hydrochlorothiazide compared to chlorothalidone. Chlorothalidone is much longer acting, and it certainly lasts longer, and so it's more tolerant of missed doses. So that, but probably would not gain much in the way of blood pressure control by going to chlorothalidone in this patient unless they're less than tolerant. One thing that you could do with the 50 hydrochlorothiazide, though, is that you can combine it with either amiloride or triamptorine, and then therefore you don't have to use potassium. I'll use. I think I agree with Sherry that when she notes the decrease in EGFR and the increase in creatinine with the combination of lisinopril, ACE inhibitor, and a diuretic. And that is fairly commonly seen. In fact, those patients who do show a reduction in EGFR generally are better protected in terms of long-term renal outcomes compared to those who do not have a reduction in EGFR. Two is the fact that generally, if it stabilizes at the 1.55 range, that's not a bad prognostic sign.
Thank you, Jack. So Jim, we obviously see a lot of patients like this in our obesity clinic. He does have obesity, poor diet, presumably, lots of the same challenges. Any thoughts on kind of increasing his motivation to make lifestyle changes? I mean, it sounds like Dr. Boland's tried, and he seems like, just from the case study, he seems engaged in healthcare, but very sedentary, very poor diet as well.
Yeah, I do have a few thoughts, and as Sherry indicated in her case, he said, constantly changing social situations, although it appears to be stable at the moment. This kind of social disorganization is incredibly unsettling for people. And in addition to that, he's unemployed most of the time. So one of the things I've learned from Dr. Rao is that folks really need some structure in their daily routine before they can really adopt habits, because habits fit into a daily routine. And so there need to be those daily triggers of, I get up in the morning, I do this, I do that, etc. And so just simply assessing that in the patient to see what his waking time is, what his bedtime is. If that's haphazard, it will be really difficult for many patients to change habits because there's nothing to really link those habits to. So one of the things that we do is ask patients to have a consistent waking time every day, which then regulates their bedtime as well. And then that provides some structure, also really regulates their circadian rhythms and everything else too. And then we could begin to work on changing habits. And one of the things that you indicated is that he's sedentary most of the time. So, one simple way to do this is to use a solution-focused approach and just simply ask, tell me about a time when you've been more active in the past, physically active. What did you do? And how did that work for you? And allow the patient to come up with that solution. If the patient doesn't respond to that and doesn't seem to have any motivation, then you can ask some questions about how important is it for you to become more physically active, to lose weight, and make that linkage between weight and blood pressure. I assume you've probably already done that, but if you haven't, be sure to make that linkage for the patient. And then ask about importance and understand, ask him why it's important for him to add a certain number from 0 to 10. Do the same for confidence. And then often those responses yield some small change that a patient might be able to make. It could be salt intake, it could be more physical activity, and you can begin to work from there.
Great, thank you. And just to Jim's point, I started asking all my patients, not just in our obesity clinic, in my primary care clinic, those that are in this situation, they live alone, they're unemployed, and they have chronic illness. How do you spend your time? assuming that they're actually having an enjoyable day. And quite often that is not the case. They would rather be doing something, or they'd rather have some sort of structure. And the response is like, I don't do anything. I just sit around and watch TV, or I go over to my cousin's once a week or something like that. So it's not like they're living the dream by any means. This is not a choice for many folks. They just don't have a lot of social connections or opportunities to be more active, to have more structure. So if we can provide that, if we can give them something to work on, it sometimes is really helpful to patients, at least in my experience. Adam, last word to you on perhaps his social circumstances and how to overcome them to improve blood pressure control.
I would really echo what Jim and Goutham were saying. I guess so it sounded to me, Sherry, that like this is a very vulnerable, this man's in a really vulnerable situation if he's so his health is not super great. He's had past housing instability, he's struggled with employment, so like, you know, in his grand view of things, my suspicion is that like blood pressure is like probably like pretty far down the list of life priorities. So one possibility is like, well, how do we align his life priorities to blood pressure? But then, you know, maybe even before going there, like I'm just a little curious about like what type of healthy social interactions and social relationships and activities does he have in his life, if any? Because I think that might be a really important starting point, because if folks don't have relationships at work and they're not really going out, then and then, you know, trying to align activities like healthy eating and active living to healthy social relationships. So like if there is somebody in his life who can go for a walk with or spend time with or have a healthy meal with more regularly than he currently does, so sort of like aligning the behavioral elements to the social elements is always a beneficial strategy. And then the last thing I would just mention is like whether there are any sort of soft institutional supports in his community. So, you know, does he live near the YMCA in Bedford there, which is a fantastic community resource that I'm aware that you guys have? Or are there other sort of, you know, relatively low cost, open door community resources where he could engage in more activity?
Thank you, Adam. Okay, we've definitely got to move on. So we're going to move on to our second case with Mary Lee Clemens. Mary Lee, take it away. How to motivate him, and what dietary recommendations you might recommend that he could adopt.
Yeah, so I think there's kind of a couple of things. One, there's the fact that kind of in those contractor positions, they have a tendency to focus on fast food and other options. So there are ways of finding some better options within that. You mentioned Chinese food. The sodium ends up being one of those things, but actually it tends to be very high in sugar as well, which is one of those kind of hidden elements that might be contributing to weight issues as well. And even in the idea of kind of skipping to someplace like a Subway as opposed to Chinese food, there's still kind of some of those traps of, do you get the tuna salad that's full of mayonnaise, or do you get something that's leaner and lower in sodium and that sort? So kind of thinking about what some of those other options that, one, might provide variety, and two, also provide some lower sodium and lower fat and sugar kinds of options to help with weight. And with the family-based side, it seems like there might already be challenges. I'm not sure how old the kids are, but some activity and some eating changes that might be focused on either spousal relationship or with the kids might be a way to continue to kind of help motivate him. And it takes some of that change off of what impacts him, but kind of setting up modeling for his kids. So now it becomes more about the kids' health than it is about his. And sometimes you can work with parents on that side to kind of shift that focus outward to get them that benefit.
Thank you, Chris. A couple of questions. One from the mental health folks is, and I think we're all kind of thinking, those of us who are physicians, on the same line, is this secondary hypertension? So, Marilee, does he have sleep apnea that you're aware of, or any other secondary cause? Has he had an renal ultrasound, anything of that sort that might indicate something else?
He does have sleep apnea. I do not know if I don't believe he had a renal ultrasound. I'm not sure if that was recommended like during his first nephrology visit or not. But as far as just like looking in the chart, it does not look like that's been done.
Jim, maybe you and Adam could have the last words. Any thoughts on, I think motivation is a big factor. The first patient seemed like he was actually motivated, making changes and moving in a positive direction, but this guy, not a whole lot of interest or concern about hypertension. How would you address that?
Yeah, and to begin, of course, the provider wants to make that linkage between whether it would be blood pressure and weight or salt and blood pressure, whatever target you want to focus on where you think you might be able to make some progress with the patient, and make sure the patient really understands that linkage and the impact that blood pressure can have on his health. What are the risks of high blood pressure for his health? And then two questions you can ask simply are, what's the best thing that can happen if you do control your blood pressure or reduce your salt intake? What are the best things that can happen if you do that? And reflect their responses and allow them to really expand on that. And the second question would be, what are the worst things that could happen if you don't control your blood pressure? And that's a quick way to help the patient build some motivation, hopefully, for change. You can work from there. You can also assess the importance simply on a scale of 1 to 10, as I was mentioning earlier, and then their confidence in being able to make change. So if the patient, there's motivation that's elicited from those questions, then you can assess confidence. And that's often where we see real deficits on the part of patients. They often will say that it's not important, but what they're really, when you get to the confidence, it's not important because I don't believe I can do it. And then you can begin to devise ways to implement this. So one step we do with patients is, if fast food and sodium is a problem, to reduce those unhealthy fast foods to a certain number of days per week and begin to taper that down. And I like Chris's suggestion, if they're going to stay with fast foods, then have those healthy fast foods on a number of days per week that then increases over time, and you can work with them to do that. So that would be a simple target that I might suggest to work on.
Thank you. Jackson wanted to make a comment as well.
Yeah. This patient is on 6 medications, but I would not classify this patient as resistant hypertension. If you look at these 6 medications, the carvedilol, the doxazosin, even though the losartan have fairly similar mechanism of antihypertensive action, and also very low dose of the carvedilol. Certainly, the minoxidil is not that effective along with this regimen, and certainly the furosemide is not effective once a day as an antihypertensive. So that a couple things that we probably would recommend. One is that he develops edema on the amlodipine. What you might try is switching to diltiazem. You'll see less edema, probably a little bit better blood pressure control, unless, especially if you go use doses above 240 as opposed to lower doses. Diltiazem antihypertensive doses should range between 240 and even up to 540, but certainly up to 480. The other is carvedilol. You could probably discontinue that. That's a very low dose one. It's twice a day. The hyponatremia, that's a little bit disturbing in a 57-year-old obese man who is active and might request an assessment in terms of the reason for that. Furosemide, if you're going to use it, it should be, you may be able to get away with using it twice a day. The minoxidil is also probably not used, so that not necessary. So that if there's the losartan would consider increasing, going up to olmesartan, which is a more potent ARB. Add diltiazem, stop the carvedilol. Eplerenone is much more expensive, might go to amiloride if you need for potassium sparing. But there is probably, that would be the last add-on that would use in this, would retain the doxazosin, but as I said, would probably stop the minoxidil and furosemide. This will give you once daily medications and probably better blood pressure control.
Thank you, Jackson. I'm just going to throw the last question maybe to Adam since he's with us. So Anissa has asked, can you order home health to assess compliance? So I'm just curious as to how you might get a more accurate measure of this gentleman's compliance, Adam.
With self-report, and I think, you know, home health is certainly an option. I don't know if that's something that's really going to be feasible in this situation. It seems like you'd have a hard time getting a justification for that. Sometimes if there's a family member, friend, or co-resident, that's an option, is to say, like, well, would you be willing to bring somebody else to a visit to talk with it? And really that's less about checking in on somebody and more about thinking about it as like surveillance of whether they're engaging in the healthy things that we want them to do, but really thinking about it as somebody to help support them in engaging in healthy activity. I think this chat comment is good. Risk of impotence and concerns about sexual health are important, and I actually think that would be something to address. Like, so, you know, sort of outlining, well, what are really the barriers? So thinking maybe not thinking specifically about compliance so much, but think about, like, what are the barriers to compliance? So sort of, instead of asking only about the you know, are you doing what we want you to do, but like, well, what are the things that get in the way? One of our colleagues here in family medicine likes to use a strategy along the lines of starting that conversation by saying, well, look, everybody fails to take their medicine sometimes. How often does that happen for you? So sort of disarming and destigmatizing that conversation so that it's not ridden with blame, and that you just sort of are saying, like, look, everybody forgets or fails to take a medicine sometime, including me. How often does that happen for you? So finding a way to start that conversation that really respects somebody's dignity and, you know, helps get at the barriers.
Thank you, Adam. So I'm sorry we're a few minutes over. I'm going to turn back to Shannon for a few final comments.
Just the last slide first, please. You will already have received our post-clinic survey in your email inboxes. Please complete that by 5 p.m. tomorrow. You'll receive a reminder tomorrow as well. And this activity is accredited by the Metro Health System for 1 MA Category 1 CME credit.